good morning. This is an international session, so we'll try to speak in English, and then after when you finish your presentations, we will have time to ask some questions, and we will thank if the audience make the questions in English. So I'm Tomás Datino. I'm here with David Filgueiras, and we have this hour to speak about basic research, and we have awesome speakers. So we move on. We will thank you if you try to finish your presentations on time. So try to do your best so we can have some questions at the end of the session. So go ahead.
So good morning, everybody. We will start with Professor Stéphane Hatem in Paris, and we have the honor to have him to give a talk about epicardial adipose tissue and atrial fibrillation. He couldn't make it to be here and present in person his talk, but he is now ready and available to start the presentation. Thank you, Professor Hatem. You can start whenever you want.
Thank you very much. Do you hear me well?
Yes.
Okay. Thank you very much for this invitation. I'm very sad not to be with you, but we are like before COVID with flight cancellation and all this difficulty with the traffic. So I will today present my presentation will be on the epicardial adipose tissue and the atrial fibrillation. So you know now there is more than 10 years that epicardial adipose tissue appear to be associated with the risk of atrial fibrillation. Several clinical studies have clearly show, I don't know if you can see my arrow, that this fat here at the surface of the atria is associated with the risk of atrial fibrillation. See, the question is whether this epicardial adipose tissue is just the biomarkers, or is it a player, an actor in the pathophysiology of atrial fibrillation? The first set of answer to this question is coming from this electrical mapping showing that in atrial fibrillation, like in other cardiac arrhythmia, the arrhythmogenic mechanism often originate from this epicardial area, where this epicardial adipose tissue is known to accumulate. Still with this atrial voltage mapping on the right side of the slide, it shows that when you have this adipose tissue at the surface of the atria, it is associated with modification of the electrical property of the atrial myocardium with area of low voltage. Then we need to go more in details on this relation between the fat and the myocardium to try to understand whether this adipose tissue is a player in the disease. These are the histology of human right atria. You can see this adipose accumulation here beneath the epicardial layer. And in some other area, this adipose tissue is associated with fibrosis, which is maybe see more clearly here with what we call now this fibrofatty infiltration, meaning that this adipose infiltration is replaced by fibrosis. And when you look at this histology in a cohort of patients, you found that this type of fibrofatty infiltration is more frequently observed in patients with permanent AF. We have been able, with Peter Anner from Leuven, and also Professor Halife, to show that when you develop a permanent AF in a sheep model, this adipose infiltration is indeed replaced by fibrosis, together with other modification of this epicardial area. So it looks like there is a clear crosstalk between this fat is fibrosis and the presence of the atrial fibrillation. What could be the impact of this fibrofatty infiltration of subepicardium? Different studies that have addressed this question. This is a in silico study showing that this adipose tissue is associated with a slowing of the electrical conduction and favor also re-entry of the electrical impulse. So, as said before, there is clearly an impact on the electrical property of the myocardium due to the fact that there is a fibrofatty infiltration of the tissue. Another mechanism by which this adipose tissue can modify the neighboring myocardium is by secreting adipokines. Indeed, this adipose tissue, which is shown here, secrete a lot of molecules, and first of all, it is a source of free fatty acid, but in some circumstances, it can also secrete adipokine that can have an impact on the atrial myocardium. And in this study, we show that when you apply the secretome of this fat tissue obtained in patient on the atrial myocardium, you induce a massive fibrosis. And we found that this massive fibrosis is due to the fact that this epicardial adipose tissue, but not the subepicardial, the subcutaneous adipose tissue in the same patient, secretes activin A, which turned to be a very potent pro-fibrotic molecules, which is also known in other organs like the liver, for instance. Then many different studies have looked at the effect of this secretome coming from the adipose tissue on the neighboring myocardium. And this is a recent publication in Heart Rhythm. This is the sketch of this publication showing that, in fact, these adipokines not only induce fibrosis, but have multiple effects on the electrical property, including on ionic channels. Another mechanism that can link adipose tissue and the development of the substrate of AF is immunity. This is illustrated again on this histology, showing that at the junction between the fat, the fibrosis, and the myocardium, you have cluster of immune cells. And we have been able to characterize this cluster of immune cells, which are B and T lymphocytes from the innate immunity. And actually, we are working very strongly on the origin of these immune cells and their role in the remodeling of this fat tissue. So you can see that there is many different mechanisms by which this adipose tissue can modify the electrical property of the myocardium and therefore contribute to the formation of the substrate for atrial fibrillation. Then comes the question, where this fat tissue originates from, where it comes from. On this slide, which is immunohistology from human atria, you can observe that on this epicardial layer, there is progenitor cells that are normally quiescent, not activated in adult heart. But in some patients, you can have evidence for a recruitment of these cells that can then differentiate in different cell lines. And for instance, we have here epicardial cells expressing these, for instance, wind tumor markers together with expression of mesenchymental cells observed in the subepicardium, including peripheral. So the question was, does progenitor cells resident in the epicardial layer can be the source of adipocytes? And one way to answer this question was to use this mouse model where the epicardial cells are tagged with a dye that can allow to follow the epicardial cells after they undergo a differentiation process. And indeed, when you submit these cells to high-fat diets that generate obesity and adipose tissue in the atria, you can see that some of these adipocytes express the red markers of epicardial cells, indicating clearly that these adipocytes come from progenitor cells located resident in the epicardial layer. Then the question is, what are the factors that recruit these cells and make them becoming adipocytes? We first test the secretome obtained from adipose tissue and found no effect on epicardial progenitor cells that we can maintain in culture conditions. In contrast, when you take a natural tissue that also have its own secretome and that you apply to progenitor cells here, you induce a massive adipogenic differentiation. And so what we found is, what we try to do is to identify which factors secreted by the atrial myocardium that can induce the differentiation in adipocytes of epicardial cells. And the strongest candidate was the atrial natriuretic peptide, that, as you know, it is normally secreted by this atrial myocyte in response to some sort of mechanical stretch. And using different strategy, we show that myocytes, indeed, when they are co-cultured with epicardial progenitor cells, can induce adipogenic transformation of the progenitor cells. And it is the atrial natriuretic peptide which is involved at low concentration. It's a very potent adipogenic factor. So it's looked that there is a switch, a signaling switch between cyclic GMPC and cyclic AMPC signaling pathway, which is controlled by natriuretic peptide. We found a lot of this receptor in progenitor cells, and that can induce the transformation of these epicardial cells, recruit from the epicardial layer, and transit through an adipogenic differentiation. Then we try to, again, examine why some of these sub-epicardium become fibrotic. There is the immunity, but also you can see that some of epicardium, this is a human atrial section, are right away very fibrotic. So what we observed, we developed mice and rat model of the atrial cardiomyopathy associated with heart failure, which is a classical condition where you reproduce the atrial remodeling, the vulnerability to atrial fibrillation in small animals. And you can see that very early after the beginning of the atrial cardiomyopathy, you get the reactivation of the epicardium with first an adipogenic transformation and then fibrosis. We also used our mice with the epicardial cell stain with tomato and found that it can go to fibroblasts. So then we isolate cells from human heart and mouse and found that there is another switch in addition to natriuretic peptide, which is angiotensin II, that can induce, in this case, the transformation of epicardial cells in myofibroblasts. So there is subpopulation of cells in this epicardial layer that we have been able to isolate and identify using this new approach of single RNA sequencing at a single cell level, and found that indeed, if you look at the right side of the panel, there is progenitor cells that can go to myofibroblasts or adipocytes, depending on the switch, which are regulated by natriuretic peptide or by angiotensin II. So this biology of the epicardium is clearly a crucial element, determinant of this fatty fibro remodeling of the cellular epicardium and the constitution of the AF substrate. Another factors that probably play a key role in this accumulation of fat and this transformation is the metabolism. And there is this very elegant work done by the group of André Carpentier in Quebec, Canada. They use this PET imaging after high-fat diet, acute absorption of high-fat diet in metabolic syndrome people. They observed a massive accumulation of fatty acid in the liver, but first of all, in the heart, seeing that the heart is highly sensitive to the metabolic conditions of an individual. And we have recently found that a mouse, which is characterized with almost no fat tissue in the heart, if you submit these animals to a high-fat diet during prolonged of time, you transform the mouse with a beta oxidation in the myocardial metabolism, with a fat accumulation, vulnerability to AF. And what we found is that when the capacity of the myocardium to metabolize this excess of dietary fatty acid, it accumulates fat through an elongation process, and among this accumulation, it generates adipocytes. So metabolism is probably one important target, very upstream in this accumulation of adipose tissue, explaining also why obesity is associated with high-fat diet and increased risk of atrial fibrillation, although it's not probably the only mechanism. So there is some sort of vicious cycles that taking place here between the metabolic status of patient, notably obesity, metabolic syndrome. We have very interesting data that we present at the ESC on the impact of metabolism on adipose tissue, which is in a very early event, like for other fat tissue in the visceral, vast fat tissue in the other part of the organism. And this accumulation of adipose tissue contributes to the transformation of this myocardium, as I showed you before. So now in clinical practice, how can this be translated? We're not in the atria, but we are in the coronary artery. This is a very elegant work done by the group at Oxford of Caris Antoniades. They observed that the texture of the adipose tissue around a coronary artery, where there is a lateral plaque, this texture is highly dependent on the inflammation or oxidative stress of the plaque, such as the plaque can diffuse factors that will transform the texture of the adipose tissue. And they found that with CT imaging, you can visualize this transformation of the texture of the adipose tissue that they call the fat attenuation. They follow this first series of study by another study where they compare this texture of the adipose tissue and the transcriptome. And they found that it also is modified with the transcriptome, and they call that the fat transcriptomic index. So they have been able to establish a marker, an imaging biomarkers using CT scan in clinical practice that tell you how is your adipose tissue around an artery. And they found that these biomarkers can predict, for instance, the outcome after coronary syndrome, acute coronary syndrome. And this fat attenuation index is coming in the heart and notably in the atria. There's a series of studies that start to investigate what is the significance of this fat attenuation index. With all what I said before, we know now that this adipose tissue is not a passive tissue. It's highly regulated. And so therefore, to get insight on this texture biology in patients may help to identify risk patients for which this adipose tissue contributes to the progression of the atrial cardiomyopathy and the risk of AF, but also of stroke. And this is the type of study that we can start to read now, where people quantify this fat attenuation index. Another parameter that probably will also transform the way we're going to manage patients with this remodeling and using fat is the atrial strain. There are developments today in MRI, but also echo, such as the atrial strain will become biomarkers in clinical practice. And we found that in a previous work with a group of Alban in Paris, that more you have fat and fibrosis in your atrial myocardium, more your atrial strain is reduced. So this strain, which is a fascinating parameter that is probably under study yet, but that probably will progress, it's a very strong biomarker of the trophicity, including histology, but also biological property of the atrial myocardium that can be used. So we have said with different partners in Europe, including the CINIC in Madrid, that a consortium, a European consortium, to develop a platform, a digital platform, to help to develop new biomarkers for early identification of the progression of the disease using this fat imaging, but other parameters, and with that going to be confirmed to patient cohort, etc. I will not go in detail, but just to tell you that this study on the fat tissue probably will open new translational perspective, not only for biomarkers, but also for the treatment, notably with the immune response and the metabolic status, that probably are two targets very important during the progression of the AF risk. And so finally, I would like to thank you for your attention and thank you to, and again, I apologize not to be with you. So large part of this work has been conducted through this European network. And I think that Europe is probably a very important frame for all this translational research on AF and atrial cardiomyopathy. Thank you for your attention. I'm ready to answer the question. Thank you,
Stéphane. Please stay wired because we will have the questions at the end of the session. And we move on to the next presentation by Jorge García. And the title, you can see it, it's Insights into Atrial Fibrillation Mechanisms from Advanced Analysis of Wave Propagation Patterns. Please try to adjust your presentation to the given time.
Thank you, Tomás. Well, these are my conflicts of interest regarding this session. Well, I could have made an introduction about how AF and its associated remodeling evolve over time, but I don't think that is needed in this forum. So let's cut to the chase and talk about the electrical mechanisms that may maintain AF. They can be classified into two categories. First, let's see the mechanisms that would imply that there aren't any localized drivers sustaining AF. More than 60 years ago, Moe postulated that fibrillation could exist as a stable and self-sustaining state, independent of how it was initiated, and that would be determined by multiple wavelets propagating randomly throughout the atria. 50 years later, the so-called double-layer hypothesis suggested that AF is maintained by epicardial breakthroughs that continuously generate new breakthroughs emerging at the contralateral atrial layer due to endoepicardial dissociation. Both the multiple wavelets and double-layer hypotheses would have important practical consequences because they would make it impossible for a limited ablation to successfully restore sinus rhythm. The second category would include those mechanisms that postulate that AF is maintained by localized drivers. That would imply that AF may be terminated by targeting such localized drivers, and that localized drivers can be foci, arising usually from the pulmonary veins in paroxysmal AF and even from other regions in persistent AF, microanatomic intramural reentry anchored to fibrosis-insulated atrial bundles, and last but not least, rotors in the form of two-dimensional spiral waves or three-dimensional scroll waves that propagate through the atrial tissue and interact with anatomical and functional obstacles, which leads to fragmentation and new wavelet formation. But do rotors really exist? Well, those groups challenged the existence of rotors in a 2015 paper. Their claims were based on the analysis of epicardial signals acquired with high-density multi-electrode plates in 12 patients with persistent AF undergoing cardiac surgery. They argued that they could only see incomplete reentries that they call wannabe reentry. They also reported that all wavefronts emanated from foci and breakthroughs, and therefore they should be the drivers of AF, even although they did not perform ablation to demonstrate this. 6 years later, in a 2021 paper, using the same data from the same patients, they suggested that rotors are really artifacts of phase mapping, that is a methodology widely used for mapping cardiac fibrillation. And what is phase mapping? It is a signal processing technique that was originally designed for high-resolution optical mapping to visualize the propagation patterns during cardiac fibrillation by determining the local phase of the activation and recovery cycle at each time point. Here you can see a phase movie from optical mapping data acquired from a SIP heart with persistent AF with high spatiotemporal resolution. As you can see, this approach enables automatic detection of phase singularities defined as the pivoting points where all phases converge. They are the small white circles. Rotors, of course, pivot around phase singularities, but not all phase singularities are a consequence of rotors. Indeed, many phase singularities are simply wave breaks rather than rotor pivoting points. I think that most of you will agree with me in that phase movies can be considered an intuitive way of displaying activation patterns during fibrillation. Here you can see the mechanisms by which Waldo and colleagues propose that long-duration phase singularities are created in the absence of two rotors, mainly repetitive waves that occur but without completing a single rotation and get blocked, or wavefronts propagating in opposite directions with a line of block in the middle. And yes, of course, that can actually happen, and that is why phase mapping is not very specific in detecting rotors. However, that is a long way from saying that rotors do not exist and that AF is exclusively driven by foci and breakthroughs. In my opinion, these and other authors might have missed the true nature of the patterns because they use multilateral plaques or basket catheters that don't offer the spatial resolution needed to discern the underlying mechanisms. Moreover, they rely on activation mapping, that is a methodology designed for arrhythmias with spatial coherence, but that may not be the most appropriate strategy for fibrillation. And just in case some of you still think that long-duration rotors don't exist and are actually active out of phase mapping, I would like you to see this optical mapping movie. It is raw data without any type of filtering and, of course, without phase mapping. You can see the left atrial appendage of a pig with a prior arterial infarction that had been in persistent AF for several months before the experiment. The rotor you can see went on and on and on for several minutes. Is this wannabe re-entry? Well, clearly it's not, so I rest my case. Of course, it's not very common to map such long duration two-dimensional rotors in one surface. Later, I'll try to explain you why is that. But now to close this activation versus phase mapping subject, you should remember the following key points. Both methodologies need multiple signals from multiple sensors or electrodes and depend on their location, contact, separation, and filtering. Therefore, when signals with low spatial resolution are used, for example, multi-electrode catheters or multi-electrode plaques, activation mapping is more specific but less sensitive for rotor detection than phase mapping because re-entry may be detected as centrifugal activations. Phase mapping is more sensitive but less specific for rotor detection than activation mapping, since focal activations or unrelated wavefronts combined with lines of log may be displayed as rotational activity if reach the surrounding electrodes sequentially. For these reasons, and since in the clinical practice we are usually forced to use low spatial resolution recordings from multi-electrode catheters, we thought of a methodology that could detect the footprint of rotational activity with high sensitivity and specificity regardless of the spatial resolution available. And we did that by detecting this rotational footprint individually for each signal or electrode, which made the approach resolution independent. Well, we realized that amplitude and frequency modulations, like the ones used in radio broadcasting, were actually present in atrial signals during AF, although of course in a completely different range of frequencies. And since the core of a rotor is excitable but an excited tissue, the amplitude of the local atrial signals should decrease when a rotor is approaching and should increase when a rotor is going away from the spot. At the same time, as the source of waves, in this case a rotor, approaches a spot, the perceived frequency at the spot should increase, and as the source of waves goes away from the spot, the perceived frequency at the spot should decrease. This is called Doppler effect. Therefore, we hypothesized that if we look for a simultaneous increase in the amplitude and frequency modulations present in atrial signals, we could detect the footprint of rotational activity. Here you can see an example of a rotor drifting across the left atrial appendage of a SIP heart with persistent AF. The white pluses that are you going to see are the locations where simultaneous increases in amplitude and frequency modulations are taking place. Note that they anticipate the rotor passing through those locations later. All the calculations are performed for the signal in each pixel individually, and that is why this approach works well even with low spatial resolution. Now you can see in red the atrial spots that the rotor has actually passed through, and now in red the locations detected by the FM-AM algorithm. You can see the great similarity between both footprints. Well, enough about rotors for a minute. Let's talk now about foci and breakthroughs. Here you can see some snapshots from a phase movie in which centrifugal activation from a specific area can be seen for a short interval of time. Note that since there aren't any white pluses, it means that the algorithm is not detecting simultaneous increases in amplitude and frequency modulations, so a rotor does not seem to be around at that time. Therefore, this pattern could be classified as true focal activity or maybe a breakthrough from a non-reentrant wave from the other layer, according to the Alessis and de Groot's double layer hypothesis I talked about earlier in this presentation. Now you can see another centrifugal activation, but unlike the previous example, white pluses are actually not displayed, which means that a simultaneous increase in amplitude and frequency modulations is taking place at that time, and therefore a rotor should be in the surroundings. And indeed, the rotor finally makes its appearance in the form of a figure of 8 reentrant activation after almost 500 milliseconds of breakthrough activation. Now you can see the signal from the spot marked with a square with a simultaneous increase in both amplitude and frequency modulations. That probably meant that the initial breakthroughs were the Epicardial manifestation of an intramural reentrant score wave, in other words, a 3-dimensional intramural rotor. Sorry, I know I said that I had talked enough about rotors, but this is key. Here, you can see a schematic of this kind of situations. What we call rotors are actually the two-dimensional manifestation of three-dimensional objects of functional reentry that are called square waves. Depending on the orientation of their filament and the map surface, endocardium or epicardium, they can be seen as two-dimensional rotors, figure-of-8 reentries, or in many cases simply breakthroughs. Therefore, many of the so-called breakthroughs or centrifugal activations seen in many mapping approaches may be the two-dimensional manifestations of a rotational intramural square wave. And yes, I know it's very small, but please don't try to read what is in this table. It's a pity, but we don't have the time to review the different methodologies that have been used in the latest years for mapping AF activation patterns in patients. What we can say is that different approaches use different technical solutions, different mapping strategies, even different ablation targets, and therefore provide different descriptions of the AF alleged drivers and their spatiotemporal stability. For example, some see long-standing drivers, and others see short-lived but iteratively appearing drivers in restricted locations. But in general, most methodologies coincide in that there is a predominant rotational nature of AF alleged drivers. Around 70 or 80% of the alleged drivers detected by different mapping approaches are rotational. Interestingly, some of these seemingly different underlying mechanisms might converge if one considers that rotors, breakthroughs, and even localized irregular activity may be dynamic manifestations of the same mechanism within the three-dimensional structure of the atria that would be intramural reentry. Anyway, all this data together suggests that activation patterns during AF are mostly of rotational nature. But are all those alleged drivers truly relevant for AF maintenance? Well, we think not all of them are relevant. However, most mechanism-based approaches target and ablate these alleged drivers regardless of their activation frequency dynamics. Here you can see a schematic of a structurally and electrically remodeled atria where several activation patterns might actually coexist. But many computational animal and human studies support that AF is maintained by high-frequency leading drivers that create a hierarchy of progressively slowing activation rates as the wavefront propagates from their source. Such leading driver regions would host reentrant drivers in many cases, but not all reentrant activity would act as a driver, since rotors are also commonly found in passive bystander regions. Indeed, we perform a quantification of rotational footprints and analyze their spatial correlation with truly leading driver regions in peaks with self-sustained long-duration persistent AF. Well, please, fasten your belts. Around 3/4 of all rotational footprints were found outside leading driver regions, and that regardless of the temporal stability required to identify these rotational footprints. That means that only a minority of these rotational activations, specifically the fastest ones, potentially contributed to AF maintenance. And I'm sure that many of you now are thinking, well, this hierarchy concept makes sense in theory, but when it was tested some years ago in the radar AF trial, the results were not the ones that people were probably expecting. And I completely understand that thinking, but although I believe the hierarchy concept tested in that study was completely right, the mapping catheter technology, the electrode sites, and the signal processing algorithm most used at that time, that was dominant frequency of bipolar signals, were not optimal for such a task. Here you can see an atrial bipolar signal during AF and its corresponding spectrum. In this example, dominant frequency, that is the frequency of the highest peak in the spectrum, is a very good estimate of the actual atrial activation rate. But here you can see another bipolar signal whose spectrum has a challenging interpretation due to multiple spectral peaks of similar height. Why this happens? Well, let's see step by step the several factors that may bias dominant frequency. Here you can see a completely periodical sinusoidal signal whose spectrum displays a single spectral line at the frequency of the sinusoid. If the signal is still periodical but not sinusoidal, harmonic peaks at double, triple, etc. frequencies make their appearance at the spectrum. Some of these harmonic peaks may even be higher than the peak that reflect the periodicity of the signal. In this example, that peak would be the one at 8 Hz. But let's come back again to sinusoidal signals, not to complicate things too much. So if the signal have a slow amplitude modulation, signal theory predicts that peaks will appear at both sides of the main one. But the faster the amplitude modulation, the more separated these additional peaks are, and they might even be higher than the one reflecting the periodicity of the signal. And now you can see an example of what happens with the spectrum of signals with marked frequency modulations. Now the spectrum is full of peaks of different heights, and again, the highest ones are not the ones that best reflect the average activation rate of the signal, that would be 8 Hz. And finally, a quite realistic situation where the time intervals with the highest instantaneous frequencies show the lowest amplitude and vice versa, which bias dominant frequency values, since the spectral peaks corresponding to the highest frequencies have less power than the peaks corresponding to slower and higher amplitude activations. Note that dominant frequency is 5.6 Hz, but the average activation rate is actually 8 Hz. Therefore, dominant frequency is biased by signal morphology, amplitude and frequency modulations, and is not always an accurate estimator of activation rate during AF. For this reason, we propose the use of time domain analysis of unipolar signals to estimate atrial activation rates and hence the hierarchy of each atrial location. Although accurate determination is challenging with complex signals and requires properly designed and robust algorithms that are less computationally efficient than those for determining dominant frequency, these time domain analyses are potentially more accurate than dominant frequency if properly designed. And in addition, they are not biased by morphology, amplitude, or frequency modulations. They also enable the tracking of dynamic changes in the local activation rate. And in the case of our IFM-IIM methodology, it also enables the automatic detection of rotational footprints, as I explained earlier. Using this approach in sequentially acquired signals with multipolar catheters, we demonstrated that hierarchy maps of activation rate measured by the median instantaneous frequency modulation at each spot are stable intra-procedure and seem stable even in the long term. Here you can see the median IFM maps that we use as hierarchy maps in a peak that had been in self-sustained persistent AF for the last 6 months. In that map, there were 2 main regions that display higher than surrounding activation rate, one at the coronary sinus and the other one at the insertion of the superior cava vein with the right atrium. We call that kind of regions leading driver regions. Note that rotational footprints that are marked with squares were present both inside and outside these leading driver regions, which highlights that rotational activity is sensitive but not specific for the regions truly driving AF. Now you can see the fastest and therefore the highest hierarchy signal in the whole atria. It was located at the coronary sinus and displayed clear amplitude and frequency modulations, which indicated that there were 1 or more rotors on the surroundings. These leading driver regions were ablated and persistent AF terminated and was no longer sustained on reinduction. Now you can see a map acquired the same day, but 2 hours and a half earlier. This map is virtually identical to the one used to guide ablation. This intra-procedure stability of this kind of hierarchy maps was confirmed in all the peaks in the study. Indeed, this same peak was mapped 78 days earlier. Note that leading driver regions, although less electrically remodeled and therefore slower at that time, were roughly similar. This is only one example, but ablation of leading driver regions acutely terminated and rendered persistent AF non-inducible in 92% of procedures in peaks that had been in self-sustained persistent AF for several months before the mapping procedure. And to translate these findings into the clinical practice, we have recently started a clinical trial to test this methodology for high-gain ablation in patients with symptomatic persistent AF despite 2 or more pulmonary vein isolation procedures. We also perform confirmation of the PV isolation at our index procedure because it's an inclusion criterion. Therefore, for the time being, we're being very conservative, and we are only testing this approach in patients with persistent AF refractory to confirmed pulmonary vein isolation. Patients are implanted with a subcutaneous implantable loop recorder from 1 month before the index procedure to at least 1 year after the ablation procedure to confirm AF recurrences during follow-up. We perform percutaneous catheter mapping and ablation of leading driver regions guided by our hierarchy maps. And if we identify highly complex substrates during mapping in which targeted leading driver regions with catheter-based ablation may not be feasible or could be associated with a higher risk of complications, the catheter procedure is complemented with an additional patient-specific and minimally invasive surgical ablation approach via thoracoscopy performed by Dr. Manolo Carnero, aiming to completely and specifically target all leading driver regions detected in the hierarchy maps. The primary outcome of the study is AF freedom after 1 year of follow-up of antiarrhythmic drugs. By the way, a little bit of spam. If you have patients with this kind of persistent AF refractory to pulmonary vein isolation in your hospitals, and you don't want to give up in your quest for rhythm control, but don't know what else to do, you may consider sending them to us. Well, and now finally the conclusions. There is no consensus about the electrical patterns that maintain AF, neither regarding their type, focal or reentrant, nor regarding their localized or non-localized nature. Some of these seemingly different underlying mechanisms might converge if one considers the 3D nature of the atrial tissue and the different spatial resolution, mapping, filtering, and interpolation methods used to display the atrial electrical data. For example, rotors, breakthroughs, and localized irregular activity may be dynamic manifestations of the same mechanism within the three-dimensional structure of the atria that would be intramural reentry. The definition of AF driver is heterogeneous across different studies and methodologies. Most of mechanism-based approaches target and ablate these alleged drivers, around 70 or 80% being rotational, regardless of their activation frequency dynamics. However, rotational activations are sensitive but not specific to true leading driver regions. Thus, many mechanism-based ablation approaches may be potentially unspecific and detect secondary patterns of activations as drivers. We consider that, regardless of the underlying electrical activation pattern, it is important to establish a hierarchy criterion based on the activation rate to be able to discern which alleged drivers are truly relevant for AF maintenance. This would prevent unnecessary scar formation, potentially reducing the likelihood of iatrogenic atrial tachyarrhythmias. Of course, while we wait for less destructive strategies than ablation to target true driver regions. And finally, the identification of these true driver regions requires advanced signal processing algorithms to accurately measure atrial activation rates, either for complex or low voltage signals. And that's all. Thank you very much.
Dr. Quintanilla, thank you for your fantastic presentation. We move forward to Dr. Sami Noujaim. He's coming for the University of South Florida, and he's very focused on understanding the mechanisms that may terminate atrial fibrillation using antiarrhythmic drugs. So his talk is going to be about mechanistic insights into novel antiarrhythmic drugs for atrial fibrillation.
Good morning, and I wish to thank the organizers for their kind invitation, and I am very happy to be here to share with you some of the findings that we have produced in the lab. As you know, atrial fibrillation treatment is inadequate, particularly as the atrial remodeling progresses from paroxysmal to the persistent stages. Most clinically available antifibrillatory agents that are used in the management of AF are marred with ventricular pro-arrhythmic side effects. And since the anti-arrhythmic pharmacotherapy remains an important line of defense, there's always a need to develop a new generation therapy geared towards the effective prevention of persistent AF without affecting ventricular electrophysiology. Remodeling in the persistently fibrillating atria is very complex, with many changes occurring from the transcriptional to the post-translational and epigenetic levels, resulting in an atrial substrate that is conducive for the perpetuation of atrial fibrillation. An elegant body of work that was generated in the laboratories of Ursula Ravens, Dobromir Dobrev, and Stanley Nattel demonstrated that in atrial myocytes from patients with persistent atrial fibrillation, as well as in animal models of tachypaste-induced persistent AF, there is a constitutively active and parasympathetic stimulation-independent acetylcholine-activated inward rectifier potassium current. I'm just trying to find my pointer. Okay. And the key here is the constitutively active IKACH. I'm going to define what IKACH is. The molecular correlates of IKACH are KIR 3.1 and KIR 3.4. The muscarinic receptor activation leads to the IKACH via a G protein coupled mechanism. IKACH is expressed mainly in the atrial myocardium, but is largely absent in the ventricles. And it mediates the vagal influence on the heart, and its activation shortens the atrial action potential duration. This is a cartoon of the canonical way of IKACH activation during normal electrophysiology, where acetylcholine binds the M2 receptor at the surface of the atrial myocyte, and the M2 receptor is a GI protein-coupled receptor, which leads to the activation of the G protein, whereby the alpha and the beta-gamma subunit of GI separate, and the beta-gamma subunit directly interacts with the intracellular domain of the channel, leading to the channel activation and to the flow of potassium through the channel. So this is the canonical way of IKACH activation. However, as I told you, during or in persistent atrial fibrillation, this current is remodeled and becomes constitutively active. And it is independent of the M2 mechanism of activation. It's not entirely clear why it is constitutively active. It is thought that perhaps there is phosphorylation of the intracellular domain of the channel via PKC epsilon, which causes the channel to remain open and would act as a regular inward rectifier potassium current like, say, IK1. So our hypothesis is that IKA's blockade slows down persistent AF and leads to its termination. And in order to test this hypothesis, we studied the effect of tertiapine Q on persistent AF in a tachy-paced sheep model. What is tertiapine Q? Tertiapine Q is a 21 amino acid synthetic peptidotoxin that was originally isolated from the venom of the European honeybee. So this is my European connection to this project. This is an NMR structure of tertiapine Q right here. And over here, we show a molecular dynamics simulation that tried to help us understand how tertiapine binds to the IKACH channel. The channel is shown right here in green and in yellow, and tertiapine Q sits right at the extracellular domain of the channel, and the C-terminus of tertiapine Q, in fact, kind of pokes into the opening of the pore, occluding the channel and preventing the flow of the current. In the heart, IKACH is a specific and potent blocker of IKACH, and the IC50 is about 10 nanomoles. So in the sheep model of persistent AF, we conducted optical mapping in the isolated Langendorf perfused heart. And here I show the evolution of the dominant frequency in 3 different regions that were mapped: in the posterior left atrium, in the left atrium, and in the right atrium. So this is at the baseline control condition. And then after addition of either 100 or 200 nanomole tertiapine in the perfusate, the dominant frequencies started to decrease, leading to the termination of atrial fibrillation and the resumption of normal sinus rhythm. And after AF terminated, we tried to reinitiate atrial fibrillation, but the arrhythmia we could not reinduce AF. Based on what I just showed you, in persistent AF, IKACH block with the synthetic peptidotoxin tertiapine Q could be an attractive therapeutic strategy. However, tertiapine Q, to our knowledge, is not available for in vivo administration under conditions that could be cardiotherapeutic. That's why we thought about how we can, in fact, weaponize tertiapine Q and try to make it perhaps potentially more therapeutic. And this is why we turned to peptibodies. Peptibodies combine the biologic and therapeutic activity of a certain warhead peptide, like tertiapine. And by the way, I didn't make up the term warhead and weaponization, although I am from Lebanon. You know, we are very familiar with these terms, but this is the standard in the field, and I like it. So it combines the biologic therapeutic activity of the warhead peptide with the stability of monoclonal antibodies, and thus they are stable and safe molecules. Peptibodies are emerging as alternatives to traditional therapeutic small molecules and therapeutic monoclonal antibodies. They represent well-tolerated, viable, and potentially exciting clinical therapies. Currently, there are 2 FDA-approved drugs for use. One of them is romiplostim, that is used for immune thrombocytopenic purpura treatment, and dulaglutide for glucose control in type 2 diabetes. So we bioengineered and produced, as well as characterized, a novel and potent IKACH blocking peptibody. We designed the peptibody, which from now on in my figures would be designated as FCTPQ, as a chimeric fusion protein composed of the Fc fragment of human IgG1 with tershipine Q as the active warhead, hence Fc for the Fc fragment and TPQ for tershipine Q. This is a cartoon of the peptibody. It is a dimer. This is the Fc fragment right here, and there is a leading secretion signal that we inserted into the protein design. There is, right here, is an 8-glycine spacer to add flexibility, and tershipine is inserted right here. The construct, we transfected the construct into human embryonic kidney cells, and then those cells would start to make the protein. And since the protein has a leader sequence, the HEC cells would secrete the peptibody in the culture medium. We then take the culture medium and purify the peptibody and continue with the experiments. This is a Western blot just to show our ability to successfully isolate the peptibody from the culture. And right here is a calculation of the half-life of the peptibody in mice. So we took a group of mice, we injected them with the peptibody, and using an ELISA assay, we tracked the concentration of the peptibody over time. And we determined that the concentration or the half-life of the peptibody is about 8 hours, which is very similar to the half-life of romiplastim when it was tested initially in mice. We then wanted to see whether the peptibody is active. Can it in fact block IKACH? And is it a better or a worse blocker of IKACH compared to tershipine? And the gold standard to do that is in fact to do patch clamping. We took the HEC cells and we transfected them with KIR 3.1 and KIR 3.4, which are the molecular correlates of IKACH. And the HEC cells would provide for us, a clean system where we can measure this, this expressed current without contamination from other currents. Right here is the IV curve of IKACH in the HEC cells in controlled baseline conditions, and after we added the naked FC fragment at 100 picomole. So just the control FC fragment did not affect the current. Panel B, we showed the IV curve of IKACH at baseline control conditions, and then after addition of 100 picomole of the peptibody, we observe a significant decrease in the current. In panel C, we show the HEC cell expressing IKACH, and when we added 100 picomole tershipine Q, it did not affect the current. So we constructed a dose-response curve in order to compare the IC54, the block by the peptibody, versus by tershipine Q versus by FC fragment. FC did not affect the current. The IC50 of block for, with tershipine was consistent with what is known, about 10 nanomole. But the IC50 of block by the peptibody was about 25 picomolars, 300 times more potent than tershipine. And this pushed us to think, why is it that this peptibody is a much better and much stronger blocker of the channel compared to tershipine? We turned again to the molecular dynamic simulations, and here I show you the model of tershipine that is blocking the IKACH channel, right here at the extracellular space. This is a cartoon of the actual peptibody, where you see the FC fragment is right here, the glycine spacers are right here, and the tershipines molecules, warheads are right there. And a molecule of tershipine a molecule of the peptibody binds two channels at the same time. Calculations of the free energies of these two systems suggested that the free energy in the peptibody IKACH complex was much lower compared to the system with tershipine only, suggesting that the peptibody configuration made the binding of tershipine to the channel a much more stable process. Then we wanted to see whether now this peptibody is bioactive. Does it block IKACH in vivo? We turned to mice. We took some mice, anesthetized them, and recorded EKGs. This is a baseline EKG in a mouse. We challenged the mouse with an IP injection of carbachol, and as you expect, carbachol would activate IKACH and cause the heart rate to slow down, which is what we see here, a significant prolongation of the RR interval. Then the mice received a IV injection of the FC fragment, and that injection did not abrogate the effect of carbachol on the RR interval. But when we took a mouse, gave it a carbachol challenge, and then injected the peptibody, we saw a abrogation of the effects of carbachol on the RR interval. The heart rates picked up again and went back towards the baseline. This here is a quantification in the change in RR interval under carbachol challenge, and then after injection of the peptibody, there was a significant reversal of this prolongation when the FC fragment alone did not produce this effect. Then the next question that we were asked was, okay, this is great. So you've shown that the peptibody blocks IKACH in an expression system, in a HEC cell. Does it do the same in a native atrial cardiac myocyte? Number one. Question number two, in the atrial cardiac myocyte, is the peptibody still more potent than tershipine? And question number three, is the peptibody ventricular, does it have atrial selectivity? And we try to answer that question in these experiments right here. So we took atrial myocytes from mice, and we performed patch clamp again, and we elicited the background currents using a step voltages. In A here, you can see the currents that were elicited in response to voltages under baseline control conditions, and this is considered as the background IK1 current. Then we added carbachol to the perfusate, and upon addition of carbachol, the current increases, indicating activation of IKACH. We followed with addition of 100 picomole of the peptibody to the bath solution, and that blocked the increase in the carbachol activation case. This is an IV curve just showing that the peptibody significantly decreased the current after carbachol addition. In panel B, we show the same experiment. However, we added 100 picomole of tershipine Q to the bath solution, and 100 picomole of tershipine Q did not affect the current that was increased by carbachol, indicating that tershipine in the native atrial myocyte is still less potent than the peptibody. In panel C is the exact same experiment, however, in a ventricular cell. And as you expect, when you add carbachol to a ventricular cell, that it does not elicit an IKACH current, and the current is the IK1 background current. And when we added the tershipine to the peptibody to the cell, it did not change the current, indicating that it does not block IK1. So we took that as an evidence of an atrial selectivity for the action of the peptibody. Then we wanted to test it in an animal model of atrial fibrillation. And of course, if we wanted to test it in a sheep or in a pig, then we need a lot of peptibody to be generated, and that's a very expensive experiment to do. So we took a shortcut and we tested that in mice. However, the problem that we had was that we were unaware of a mouse model of atrial fibrillation where IKACH is constitutively active, so that we may test the hypothesis in the proper animal model. And that's when we started thinking that, hey, wait a minute, aging is an important mediator of atrial fibrillation, and in fact, AF is kind of a disease of the aging heart. So could it be that in aging, there is a constitutively, or in the aged cardiac atrium, is there a constitutively active IKACH? To answer that question, we took two groups of mice, young mice, which had about 3 to 5 months old of age, and a group of old mice, which were more than 20 months of age, which is, and we consider those old, and those would correspond to about 75 or an 80-year-old person. Although for people, I'm not saying that 75 or 80 is old, just for the mice. Yes. Here is an experiment in the atrial myocyte from the young mice. This is the baseline control. This is the baseline control condition. And after addition of FC fragment as a control, we don't see an effect on the current. This is a young mouse under baseline control conditions, and then when we added the peptibody, the current was not blocked, it was not affected. But then when we took a myocyte from, atrial myocyte from an old animal, And well, we applied the FC fragment. Again, nothing happened. But when we applied the peptibody, there was a dramatic decrease in the current. And there is no carbachol challenge here. It's just the constitutively active IKACH that is present. And these are the IV curves of several cells that were, one of them is illustrated here. So then we moved on to test the potential antiarrhythmic effects of the peptibody in mice. 2 cohorts were tested. One mouse group was injected with the FC fragment. Another mouse was injected with the peptibody. The age of the 2 groups was similar, more than 20 months old. And this is a in vivo EP study, if I may call it that, in the mice. This is the EKG on top, and at the bottom is an intracardiac electrogram that we were able to record through a catheter inserted into the jugular vein and advanced into the right atrium. A burst stimulus of about 2 seconds right here elicited atrial fibrillation in a mouse injected with the FC fragment. But that did not happen when we injected the peptibody. Stimulation, the burst stimulus did not induce AF in the peptibody injected mouse. So in 5 out of 5 animals, we induced atrial fibrillation in FC injection. However, with the peptibody, the inducibility of AF was dramatically decreased, and only 1 of the 5 animals displayed atrial fibrillation. So in conclusion, targeting IKACH in persistent atrial fibrillation is an attractive and atrial-specific rhythm control strategy. We have generated the first peptibody with proven effectiveness for blocking in the picomolar range the IKACH channel. We demonstrate that the peptibody is bioactive and prevents atrial fibrillation induction when administered in vivo to aging mice. And peptibodies can be bioengineered to provide a platform that can help in guiding mechanistically driven generation of novel ion channels modulating tools and potentially anti-arrhythmic chimeric modalities. So I would wish to acknowledge my collaborators and the funding that my lab has from the NIH and from the University of South Florida. And with that, I thank you for your attention.
Okay, now we have time for questions, but I'm sorry to say that Dr. Hatem had to disconnect, so we can't ask him questions. Pity, because knowing that in advance, we will have asked the questions at the end of his presentation, but that's it. So we have to discuss with what we have here with these 2 speakers, and I don't know if in the audience you have any question. Dr. Khalife.
One second, please. I have a question for Jorge. When will you have? I mean, you know, I love your study. You know, I'm really fascinated by the fact that you were able to find the drivers the way you have done it. When will you have a user-friendly tool available for the clinicians so they can find the drivers without having to do all the work that you do in your laboratory? Is it feasible? Is it possible to do it? How long would it take you to develop that tool?
Okay. Thank you for your question, Pepe. In truth, the tool is already available, but it's not implemented into a conventional electroanatomical mapping tool. So it's quite user-friendly, and it has colors. I think it's easy to use, but the problem is that you have to export signals from the electroanatomic system, and it takes time. So it lengthens the procedure, I think, about 15 minutes or so. while you are exporting the signals and importing into an external computer and processing the signals. But the user-friendly interface it's already there. So that's the reason why we are already trying in this clinical trial I talk about.
So what would be the next step?
We are now trying to see if we've seen that in pigs it's very effective, and in fact in 92%, I think it was in 12 out of 13 pigs with several months in self-sustained atrial fibrillation, we achieved to finish atrial fibrillation and even to make it not inducible. But we are trying to see if the same is true in patients. What we've seen until now is that terminating atrial fibrillation in the acute procedure is very difficult, and is not the percentage we've seen in pigs are not feasible in patients in the acute procedure. But the patients we have performed until now, I think they're going very well, and we've performed, I think, 10 with a follow-up longer than 1 year, and 9 out of 10 are in sinus rhythm. So I think it could be a good system, but we have to wait for more patients and try it properly.
Okay, this sounds like the Holy Grail. We hope to have these results using this technique, but we'll see. Okay, I have one question, if there's not other question from the audience. I don't know if I can pronounce your name properly. It's Noujaim? Okay, sorry. Okay, so, well, a few questions. It's interesting. It's nice to know that they're still investigating, researching in drugs, in different options from ablation. But, well, first, what do you think it will be the main role with this drug? And just research, or we can move to patients and it will be used like only to cardiovert the AFib in acute scenario, or it will be like an antibody to be used to chronic treatment to prevent AF?
Yeah, so I think an important next step that we have to address is whether this peptide can also be effective in a large animal model. And we do have plans to do those experiments in collaboration with Dr. Filgueiras, Rama, and Dr. Khalife in their pig model of tachy-paced persistent atrial fibrillation. So that's going to be a very important experiment that would be more translational. Also, we must understand better the safety of this peptide and how to make it a plausible drug regimen. How is it going to be delivered? How long it needs to be delivered? For how long the treatment needs to be? So, I mean, your questions are very valid, but I think we have a little bit of work to do in order to demonstrate in a relevant animal model before we take the next leap and start to think about whether it's going to be effective in the patient and how we're going to do that. But definitely this is, in the works.
I see. I know that it will take time, but anytime. What do you think this adds in research different from atropine? Because, okay, I know atropine have more general effects, but have you compared the effect in animals with this antibody and atropine?
Beautiful question. We did not do that direct comparison, and perhaps we should in the mice. It's going to be easy. However, I feel it's going to be an atropine is going to have, it's unlikely that atropine is going to have the same effect based on the experiments that were originally done with Ursula Ravens and Dobromir Dobrev in the myocytes from patients with persistent atrial fibrillation, where adding atropine did not affect this constitutively active IKACH current, but rather blocking the channel itself with tertiapine. That's what caused, the block of this current. But as a proof, we should. It's going to be easy to do that experiment. Yes, at least in the mouse.
No.
Yeah.
Yes. I don't know. Okay, Felipe.
Yeah, I have. Beautiful table. I have one question for Dr. Quintanilla. you showed that in experiments there is stability of the sources with time, but in humans, do you have any data, since you are going to perform sequential mapping, how stable are the sources with time using your device, your algorithm?
Yeah, we haven't tried to perform 2 maps in patients because it would lengthen the procedure too much. So we cannot be sure if the maps are as stable as in peaks in patients. But we have assumed that to perform our studies, because the procedure itself is lengthened by the mapping, the additional mapping process. You have to map in detail the atria. So you add another 45-50 minutes to a standard procedure. And if we have to wait and then perform another additional map to test the stability, I think it would be too much for the study. But it would be very interesting to have the ability to test that. But that's the reason why we did it with a realistic model of atrial fibrillation with peaks that are very, very similar to patients in the aspect that the persistent AF has been sustained for a long time, it is self-sustained, and the features of the signals and the regions are quite similar. So I guess if we could test it in patients, they would be stable as well.
Overall, you are extending the procedure around 45 minutes using your algorithm?
Yeah.
Just to map?
That's only for the mapping, and then as it's not integrated yet with any conventional electroanatomy mapping system, you have another additional 15 minutes to export the signals and process them, and then the additional ablation. But because you are not only performing pulmonary vein isolation, you have to isolate, to ablate more regions. But when they are too big, we resort to minimally invasive surgery, because it's too much to perform with catheter ablation. And in patients that have been in persistent AF for a long time, the regions are usually large.
Thank you.
Is there more questions for the audience? Professor Almendral.
Question for Jorge Quintanilla. Thank you for your presentation. Do you have data in peaks if the sources are more epicardial versus endocardial, and if you can detect, for example, epicardial sources from the endocardium, how easy is that, or how difficult could that be regarding to patients?
Yeah, we cannot test these regions in the epicardium because we are performing all the mapping with endocardial catheters, so we don't have the data about how it's in the epicardium in vivo. We have in optical mapping studies, but in fact we didn't perform the leading driver region study in optical mapping. We only use optical mapping data to test our detection of rotational footprint algorithm with the gold standard that would be phase mapping in optical mapping data, which has high resolution. But we don't have the data in peaks from epicardium of leading driver regions, and in patients I think it's not feasible with our approach.
Thank you. I have 2 questions. One is for Jorge, just for continuing with the discussion. Jorge, how often is with your system to find any interesting area affecting the right atrium? Connected with the comment from before, how feasible it is to address those areas with the technologies that we have today for ablation, which are mainly oriented to PV isolation, and how often you have to move to another type of ablation like hybrid procedures or surgical procedures. Okay, and then I will continue later with the question for Sami.
Okay, well, we see leading driver regions in right atrium quite often, I guess. In fact, in some patients, there are only in the right atrium. But I don't have the statistics here, but I think they are more common in the left atrium, but they are as well quite common in right atrium. And there are, I think, in some specific regions we can perform catheter ablation, but when it's very common, the right atrial appendage, it's usually on the right free wall, is quite common, and it usually they are quite large regions, and that regions are difficult to isolate with catheters. So in that cases, when the atrial appendage are involved, we usually send them to minimal invasive surgery.
Sami, my question, thank you for your presentation, I love it, is do we have any experience with this kind of peptibodies in humans for any kind of condition, of medical condition? What is the feasibility of using it in the future for treating AFib or on any other arrhythmic conditions? And what are the constraints for using this kind of molecules in humans?
Yeah, so there are now 2 peptibodies that are approved in the clinic. The original one is called romiplastim, and it is used for the treatment of immune thrombocytopenic purpura. I hope I said it right. And the regimen for that, the treatment regimen for managing that condition is via a sub-Q injection of the peptibody solution. And I think it's done every week or 2 weeks. So there is a clinical precedent for the use of these peptibodies, and for their safety and for their efficacy. Now, when it comes to treating an electrophysiological disease, again, it's going to take some work to try to understand, how much of that peptibody is going to be administered, for how long it's going to be administered. Are there other methods, other than a sub-Q injection of the peptibody that we can use in order or find novel delivery strategies to deliver that peptibody and to make it into a therapy? We are working on that again with Pepe and David. But to your original question, there are clinical precedents for the use of such molecules. Yes.
I have another question for Jorge. Jorge, so what's so special about the tissue areas where the driver regions are localized? Is it different? Is it something special?
Yeah, well, it has been studied in our laboratory, but they are more molecular studies I'm not expert on. But I think they have distinct features in some specific features. For example, and that is a quite surprising finding, in those areas, the people that is studying that have seen that they have a slightly higher level of fibrosis than non-driver regions, and that can seem counterintuitive because one would expect that if the regions are activating faster, they should have less fibrosis. But I think it's maybe a balance between the first level of fibrosis just to enable the rapid activation of the region, but at the same time, maybe it's delimiting a specific region in which reentry anchors more easily. So I think it's a balanced situation between fibrosis, because if fibrosis would be much higher, the region, I think it wouldn't be capable of supporting high activation rates. That's, for example, one finding, and there are others, but maybe David can talk about them more because they know them more than me.
But I have a follow-up question. So supposedly there's slightly more fibrosis in those driver regions. What makes those driver regions localized into the right or the left atrium? I mean, the level of fibrosis, or what is it that really makes those driver regions the driver regions?
Yeah, I'm not sure. I think in pigs it's related with baseline features of the tissue, because you can see in pigs that when they are in persistent AF for several months, the same regions are usually the leading drivers. And when persistent AF is going on for a longer time, there are more regions and different regions. But I think the baseline features of the tissue can influence that, especially in pigs. In patients, I think we've seen more different regions, and we don't have an answer for that. But in pigs, I think it's related with the baseline conditions of the tissue.
Okay.
Pepe, this is a very nice question, and of course, many people will be interested on that. And something we are very much interested in is in understanding the molecular properties of those particular regions. They are different. This is something that we not only see with the catheter, but that at the molecular level, they are different than the other regions. So it's not just the catheter features, it's also the molecular properties, and something very much involved on that is the metabolism. The metabolism of those cells is completely different at the mitochondrial level, at the oxidative stress, at the fibrotic level, but also at the inflammatory level. So there are many factors involved, but they are different at many different levels that we are trying to understand. And Jorge is not very much involved on that, but of course the tools are extremely important to understand what is underlying that. I have a question related also to this that connect of Stéphane Hatem with their talks. And Stéphane Hatem has shown something very interesting about the progression from the epicardial progenitors to the development of adipocytes and then fibrosis. So it seems that the remodeling is progressing, and we know in patients that if we wait too long, the scar tissue and the areas with remodeling will be much and much larger, especially if we wait above 6 months. It seems the remodeling, electrical remodeling at least, is complete in most of patients, 75% of patients we have studied in 6 months. So if we wait more than 6 months in persistent AF, many patients will complete their remodeling. So the question based on this is, what is the therapeutic window we may have, for example, for an antiarrhythmic drugs based on blocking the constitutively active IKACH, and how the fibrotic may counterbalance the antiarrhythmic effect that we may have with IKACH blocking. And also, of course, and Jorge and I have experienced that when we wait too much for patients to indicate the ablation procedure, we can see also that the remodeling has spread all around the atria, and it's difficult to target those areas with catheter ablation. So connecting those 3 talks, I think, Sami, what is your expectation about the therapeutic window we may have with animals or patients when we block the constitutively active IKACH, and also for Jorge, what is the reasonable therapeutic window we may have with catheter ablation to target those regions only with a catheter, not the surgery, because the next step is more aggressive.
Yeah, I mean, I think you are spot on with respect to what is the therapeutic window where an intervention like blocking IKACH might be effective. And indeed, I mean, targeting the arrhythmia while it is during this transition phase as the atrial electrical remodeling is taking place and before perhaps the fibrosis becomes so large, that could be perhaps a sweet spot if it can be identified, correctly, and that okay, this patient is in that stage, and now we can intervene with this antiarrhythmic modality. Is it going to be effective once this AF has been there for more than a year, and then the atrium is so fibrotic, and now it's a very complicated picture? I don't know if it's going to work, and it would be great to again use the animal model to test these two windows, one where the atrial electrical remodeling is taking place, and one long after that when the tissue has become more fibrotic, and see what would happen.
Well, regarding ablation, I think since we've seen in pigs that pigs with that have been in self-sustained persistent AF for 4, 5, 6 months, the regions are quite restricted, and you can perform catheter ablation, I think, in a reasonable way. But the patients we are now doing that are being in persistent AF for more than 12 months or 14 months, the regions that we should target for ablation are much larger. And I think if we could perform patients at 4, 5, 6 months of persistent AF, it would be a much higher chance of success in the acute procedure. Because now with these patients with so many months in persistent AF, it's very, very difficult to achieve acute success and that atrial fibrillation terminate during the procedure. Even though the follow-up is very good, but the acute endpoint is not feasible with so many months.
Okay, thank you very much. We had one more question from Dr. Guerra, but I think he ran away, and we ran out of time. So thank you very much to the speakers and for the interest the audience has shown, and with all the questions. And we think we are perfectly punctual now, so we can finish this session. Thank you very much.